everybody, and thanks very much, Noel, for the introduction. First of all, I'd like to thank the EPA for the introduction and the invitation to speak to you today. So what I'm going to talk to you today is about some research that my colleagues and I have been conducting as part of our programme of research with the EPA, which is now in its 6th year. And a major component of that programme of research is looking at the interplay between the environment and health. So this is part of a sort of a wider body of research. My colleagues here that are listed on the screen have done a lot of the hard work here. So as I mentioned, this is part of a broader programme of research that's funded by the EPA. We're not just looking at issues to do with environment and health. There are other issues that we look at. For example, there's a behavioural science stream, and we're also looking at issues, for example, to do with climate change. And I suppose where the linkages between the ESRI and the EPA have come together very well, I think, in terms of environment and health, is that at the ESRI, and particularly, I suppose, in terms of some of my research, I've been very much focused on what are termed the social determinants of health. So these are the non-medical factors that determine our health and well-being. So these are things like, obviously, the environment in which we live, but also issues, for example, to do with, the food that we eat, the conditions in which we grow up and that children are raised, sort of poverty, socioeconomic status. So all these sort of multitude of factors that determine our health and well-being. And more recently, I suppose, we've become much more interested in the role of the built and natural environment. And this is where our research programme with the EPA comes in. And if you think about, I suppose, the influence of the environment on health and well-being, you can think of both direct and also indirect effects of the environment on health. So obviously when you think about drinking water quality, that's a prime example of something that has a pretty direct and immediate impact on health if water quality is compromised. And I'm going to talk about some of the research in that area today. But there's also sort of indirect effects as well, whereby the environment and environmental conditions work through things like health behaviours to impact our health. So if you think about, for example, access to coastal amenities or recreational water spaces, these might encourage people to be more physically active, and that in turn has an impact on people's health and well-being. So really sort of interesting pathways and different impacts, both direct and indirect, of the environment on health. So I suppose just before I get into the two specific studies that I'm going to tell you about today, I'm going to talk a little bit, I suppose, about the broader, I suppose, data and methods that we use to look at the links between the environment and health. So I suppose what we're trying to do here is trying to overcome some of the methodological challenges that have been, I suppose, well elucidated in previous research in looking at the association between the environment and health. So obviously, if you think one of the big issues is trying to, I suppose, disentangle the association. So for example, if you think about people who live in a particular area, they may have poor, for example, air quality or drinking water quality, or they may be subject to environmental noise. But it's really difficult to try and disentangle that from other local conditions or other sort of factors that may be impacting on their health. So people, for example, that live in high pollution areas may also have lower socioeconomic status. There may be other factors that would lead to poor health. So it's trying to disentangle those impacts is really difficult. And we try and do that by getting data that really characterizes individuals very well. And I'll talk about that in a bit. There's also issues then, for example, with previous studies that might have honed in very much on sort of local areas. And they can be really useful and can be really useful at trying to sort of identify links between the environment and health, but maybe have less sort of generalizability in terms of the population as a whole and of interest to people, for example, in making sort of national policies. So what we've tried to do is, I suppose, use a variety of different data sources, a variety of different methodologies, and try and sort of overcome many of these issues. We don't do it perfectly, and different approaches have different advantages and disadvantages, and I'll talk about those a little bit in a moment. So as part of our research program with the EPA, we've looked at a number of different environmental exposures that I've mentioned on the slide here. Obviously, what I'm going to talk about today is drinking water quality, and this is primarily the data that we get from the EPA. But I suppose what's particularly interesting about the research that we do is that we link those data, which are by and large spatially coded, to data on individuals' health and well-being from a variety of different sources. So we have a number of different survey data sources. So for example, from Healthy Ireland, which is a survey of the adult population, the Irish Longitudinal Study on Ageing, which is a study of the population aged 50 and over, and that's one of the studies that I'll talk about today. And then also administrative data sources, and I think these are potentially a really untapped resource in terms of looking at these associations. So the hospital inpatient inquiry is one of the other data sources that I'm going to talk about today, and this is the sort of administrative data on people, so every time a person has an inpatient stay in hospital, lots of data is recorded, and we can use that to look at, for example, the burden of water-related diseases. Okay, so where I'm going to start is, I suppose, giving you some background on why this is important and why it's important to look at this in terms of healthcare utilisation and healthcare costs, most specifically. So Ireland had the highest rate for VTEC. So VTEC is a form of E. coli infection among EU member states. It was reporting 10 times the European average in 2017. So we're a real outlier in terms of VTEC infection. In Ireland, it's transmitted primarily via person-to-person contact, particularly among families that have young children. So you'll see in terms of outbreaks, for example, that creches and kind of early childhood settings are a real concern for transmission in terms of person-to-person transmission. And via exposure to water from untreated or poorly treated private water supplies. And I suppose that's where we're coming in here. There have been analyses also as well of outbreaks, an analysis of VTEC outbreaks over the period 2004 to 2012 found that water was the main cause of primary transmission. There is a requirement that these cases, it's a notifiable disease, so doctors notify local medical officers for health, and this data gets recorded then by the CIDR system, which is, if those of you are familiar with the COVID reporting, they're the agency that reports infectious diseases. So there were 923 cases reported and notified in 2017, and about a third of them were hospitalized. So it can be a really serious acute condition. 3% developed this, I'm not going to pronounce the acronym because I always struggle with it, but it's basically a kidney disease. It can be really serious in older people and in children. The major component here or source here is private well water. So what I'm going to do in the time remaining is talk to you about two studies which have used different approaches to try and look at, I suppose, the burden of water-related diseases. The first then is looking at the link between drinking water quality and healthcare utilisation in the older population, and the second then is using that administrative data source that I've told you about to sort of quantify the costs associated with water-related diseases in terms of hospital costs, so sort of the tip of the iceberg here. So in terms of the first study, in terms of the link between drinking water quality and healthcare utilisation, what I'm going to focus on here are E. coli exceedances, so VTEC is part of that, in drinking water supplies and healthcare utilisation in the older population. It was mentioned earlier, I think, in one of the questions around, an answer to a question around the health effects of nitrates pollution in terms of children, but essentially in terms of drinking water poor quality, the health effects really are concentrated in younger and older populations. So that's part of the reason why we're focusing on the older population here. And what we did was we linked 3 sources of data. It's going back to 2010 now, but that's purely because of the availability of the data. So we have EPA water quality testing results. We don't have data for those supplied by private sources, including wells, but we can identify those individuals in our data, and I'll tell you a bit about that. We have water system infrastructure maps, so we need to know where the various water systems are, and we need to link that then to individuals. And the individuals that we have are from the Irish Longitudinal Study on Ageing, and importantly here we have lots of other information about those individuals. So, you know, we can sort of isolate the effect of drinking water quality exceedances over and above other things that might lead them to have higher healthcare utilisation, such as their health status, their age, for example. So this is an illustration, I suppose, of how the data and the studies are constructed. So the red dots are hypothetical people in the tilde sample. The sort of polygons around them then are those that can be linked to a public water supply. The dark grey shaded ones are ones that have an exceedance, and the lighter grey then are the ones that don't, so there was no issue with the water quality. And the ones that don't have any polygon around them are ones that we can't map to a public water supply, but we do know, obviously by elimination then, that it's either a private supply or a well. So what do we find? Sorry, I've gone past one slide. Okay, there's a slide missing in terms of the results, but essentially what we found in terms of the results was that those individuals that were on these supplies that are shaded in grey, that have higher, that have an exceedance in 2010, that was associated with higher GP utilisation, acute hospital care, and emergency department visits. Now, interestingly, for those that we couldn't map, so that were on private wells or private water sources, there was no sort of independent effect, but we suspect that's because we can't disentangle the private wells from the group water schemes, and also that there may be a correlation, for example, with other characteristics that we've controlled for, such as health status or medical card status or age. So the second study then is looking at the impact of water-related disease on healthcare utilisation and costs using the administrative data from the hospital inpatient inquiry. And I suppose the advantage of this particular methodology is that, first of all, we don't need that data on exceedances and we don't need to know where people live. We can just simply look at the administrative data on diagnoses of people in hospital and see, you know, what is the burden, I suppose, of water-related disease to the healthcare system. It also allows us as well, I suppose, to drill down a little bit in more detail in terms of sort of local conditions and also the seasonality associated with some of these outbreaks. And we can also look at different population groups. So in contrast to the earlier study, which was focused on the older population, the HYPE data covers the entire population of people who end up in hospital in a given year. So as I mentioned, it's data from the hospital inpatient inquiry, and we use these data from 2015 to 2018, so a little bit more recent as well. The HYPE data, for those of you that are not familiar with it, it collects really comprehensive data on all discharges from public hospitals in Ireland. So not only details on people's demographics, but also really detailed information on diagnoses and procedures that people undergo while they're in hospital. And the analysis was conducted in 3 steps. So first of all, we need to know the diagnoses or the individuals that are in hospital for a disease or a condition that's potentially due to a water-related disease. And we can do that using the coding system for diagnoses that's available in HYPE. So there's really detailed codes that will tell you the disease that an individual is in hospital for. But of course, not all diseases, for example, for E. coli, would come from a waterborne source. So we need to try and attribute a proportion of those cases to waterborne sources, and then, take out, I suppose, the proportion that would be due to, for example, food contamination. So we do that using sort of external data from a number of different sources, so we can attribute a sort of a share of the diagnoses to waterborne sources. And then thirdly, we need to assign a cost. And we do that using data for the hospital costing system from diagnosis-related groups. So basically, sort of every diagnosis is assigned a diagnostic-related group, and that assigns a cost based on the resources that sort of the treatment of that condition is subject to while in hospital. So what we found was that it depended, I suppose, on the type of water-related disease, and we aggregated the diseases into a number of different groups, depending on, number one, the number of cases, but also number two, the sort of how confident we were that the source was a water-related source as opposed to another one. And you can see there, I'm not sure how well people can read the sort of the small print, but essentially the main sort of cost is for the second group. So these would account for a lot of cases in hospital, but actually in terms of cost, they're not too costly. It's the group ones actually that are the costly ones. So these are sort of conditions that require a lot of resources to treat. But I suppose the take-home message from this actually is the relatively small overall cost to the hospital system of treating these water-related diseases. You'll see there that there's a sort of a wide range between 8 and 25 million. This reflects the sort of uncertainty we have in sort of attributing the costs to a waterborne source. But if you think of that in the sort of overall context of how much we spend on healthcare and on hospital care, it's relatively small. But we are only dealing here with the tip of the iceberg. This is people who end up in hospital for water-related diseases. We've also been able to look then, I suppose, at how this might vary across different cohorts of the population. And we looked at length of stay, which is a really sort of good indicator of resource costs in the hospital. It's higher for those with a group 1 diagnosis who are older and obviously have more comorbidities, so they're just more complex to treat. So finally, I just wanted to show, I suppose, the value of using the HYPE data for this type of analysis and sort of drilling down into not only where these cases might be occurring across the country, but also in terms of the seasonal pattern. So what I'm showing you here, if you look down the left-hand side, these are hospitals. So there's 29 hospitals in the HYPE system. Under the terms of our data agreement, we can't actually tell you the names of the hospitals, but we can broadly tell you they're in Dublin, non-Dublin, and they're children's hospitals. But basically, you can see there the sort of the heat map in terms of the water-related disease diagnoses, and they're very much sort of concentrated in particular hospitals. So it's the children's hospitals, and it's some of the non-Dublin hospitals. There's also a seasonal pattern as well. So if you move from left to right, you'll get an indication then of the season. So you're moving from 2015 quarter 1 up to 2018 quarter 4, and you can see that it's very much a sort of a quarter 1 and quarter 2 issue. So I suppose what we'd really like to be able to do is drill it down into this a little bit more. There's obviously really important local conditions and sort of seasonal effects here that are working through and that we can see coming through, even in terms of this sort of relatively small resource use in the acute hospital system. So just finally then with the last minute, just to summarize, our research uses a variety of data sources and methods for the assessment of the burden of water-related diseases. All of advantages, disadvantages, but I think together can build a better picture of the burden of water-related diseases. In the older population, we've shown that E. coli exceedances in local water supply are associated with higher healthcare utilization, sort of controlling for other factors that might lead to healthcare utilization. And focusing in particular on sort of inpatient hospital care, which is sort of the tip of the iceberg, while the overall burden is relatively modest in terms of costs, there's substantial variation across population groups, regions, and times of the year. So in terms of future research, and maybe for discussion later, I think we'd really like to get a handle, I suppose, on additional costs associated with water-related diseases. So there are other aspects of healthcare. If you think about, getting sick from a water-related disease, often we might not even go to the doctor. People will sit it out at home. There'll be work-related absences. People might have to care for sick children, and that creates a cost to society. And then, as I mentioned, in relation to that sort of heat map, I think there's really interesting work to be done to link local and meteorological conditions to these sorts of patterns, and there's potential to use data from, as I mentioned, the computerized infectious disease reporting system. So I'll leave it there, and happy to take questions at the end. Thank you.